hope you guys, use the chat as much as you guys can. Test yourself whether you know the concepts really well or you don't know them at all. This is just a good opportunity to learn and dive through some really high yield topics. So with that being said, we are going to crack on, everyone. So, just first and foremost, I did want to introduce two of our mentors and our private advisors that we have on the MedSchoolBro team, and that is Fahad and Khalid, who are with us today. So I'll just give them the mic here for a second and let them introduce themselves.
Hi, everyone. My name is Fahad. Pleasure to be here. I've been working with Jake for the past few months now, and we're building out, like you mentioned, this Discord mentorship group and also a private advising group for pre-meds and for med students. For those of you who don't know me, so like I said, my name is Fahad, born and raised in South Florida, went to the University of Pennsylvania for both undergrad and med school, and now I'm going to be starting dermatology residency at the University of Miami in the next couple of weeks. And then we have Khalid as well.
Yeah, hi everyone. My name's Khalid. Fahad mentioned it, but we actually both went to med school together at the University of Pennsylvania, just recently graduated, and I'm going to be on the ophthalmology side at the University of Miami, hopefully starting residency in the next couple of weeks as well.
Awesome. Thanks, guys. I did want to mention that we will be doing a giveaway of my endocrinology guide at the end of this webinar, so do stay tuned for that. And then throughout the webinar, I will have an exclusive discount QR code for you guys to join our community. And we also have some really exciting updates, as Fahad and Khalid mentioned, when it comes to private advising and mentorship for you guys as well. All right. So today we are going to be covering everything from receptor signaling all the way to diabetes pharmacology and everything in between. So I hope you guys are ready. And first and foremost, we are going to start off with receptor signaling, which is a very, very high yield concept. And this question here is just a kind of first order, quick, discrete, active recall style question. So you're a researcher studying receptor signaling pathways and are particularly interested in a G protein coupled receptor that has a 7 membrane spanning helices. Which of the following hormones can be used to stimulate this receptor? So everyone in the chat, I want you guys to participate here. Put in the best answer. Is it EPO, FSH, growth hormone, or prolactin? Getting lots of B's, getting lots of B's. Very, very good, everyone, if you're saying B. Now, I just wanted to dive into this as a kind of more discrete question, because I think it's important that you guys do have these memorized for the STEP exam. And you might be tested on it in a discrete way like this, but oftentimes they're going to give you a situation, a vignette, right, that pertains to one of these receptors and ask you what pathway it works via, right? Is it a G-coupled protein receptor? Is it a tyrosine kinase? Is it JAK-STAT mediated? And then within your G protein coupled receptors, remember, you have your GS, your GI, your GQ pathways, right? And so on this next slide, we're going to be diving into those. I will cover EPO, growth hormone, and prolactin as well on the following slides. But if you said B, FSH, you're absolutely correct. Great job. All right. So I wanted to dive into the 3 different receptor subtypes within our GPCR, okay? And a reminder, guys, that our GCPR is our G-coupled protein, right? It has 7 transmembrane helices. And the whole point of these G-coupled protein receptors, guys, is signal amplification, right? We know there's our intermediates like our adenylate cyclase. And what happens is when those are activated, it's going to synthesize thousands and thousands of our cyclic AMP, right? So it binds on the extracellular ligand, right? And then intracellularly, you get this huge amplification of a signal. And we're going to be diving into just the GS, GI, and GQ pathways now, okay? Now, a fun little memory trick that I use is fat cat's bump legs to remember your GS and GI pathways. As you can see here, our answer here was FSH, right, which is a G-coupled receptor. I could have also asked which subtype it works on, which is GS. I could have also, right, the USMLE can often do this. I could have said, does it increase cyclic AMP or decrease cyclic AMP? And I want you to remember, everyone, that GS, S is for stimulatory, I is for inhibitory. So as you can see now in this next slide, right, here's your G-coupled receptor, right, the ligand, extracellular ligand it binds to, and then intracellular, it's going to cause this, right? what we can see here is that GS is going to stimulate adenylate cyclase, which is going to convert our ATP into cyclic AMP, and then that's going to activate our PKA, right? GI, on the other hand, is going to inhibit. So I is for inhibitory, S is for stimulatory, okay? And it's going to decrease these levels of cyclic AMP and decrease intracellular signaling, okay? So I want you guys to be able to differentiate GS, GI, and understand that these ones here are going to work on your cyclic AMP pathway. And the USMLE can test anything in between that I just talked about, okay? Everything from what type of receptor and ligand signaling is it? So is it G-coupled receptor? Is it tyrosine kinase? Is it JAK-STAT? And then it can also test, how does it affect adenylate cyclase? How does it affect cyclic AMP? So just keep in mind these high-yield principles, okay? Next, GQ is going to work via your IP3 pathway, right? And this is all responsible for increased intracellular calcium. And we know that calcium often causes what? Vasoconstriction. So you're going to think of the receptor types that work within those, okay? Another fun little mnemonic, guys, GOAT 1, 2, 3, okay, to help you remember these ones here. And in particular, right, I mentioned that these ones are going to work to increase your intracellular calcium, right? And the mediators that I want you to be mindful of in the question stems, right, to trigger this GQ pathway in your head is your phospholipase C, your PIP2, your IP3, and your DAG. Okay, these are mediators. These are words that they could use in the vignette. And I want you to always think about GQ when you see these, okay? Next, I wanted to just talk about vasoconstriction and how that relates to some of these receptors here. Reminder, right? You can just think of this with the M3, for instance, right? We know that that can cause bronchostriction. That can cause contraction of the bladder, right? We give something like oxybutynin to contract that. That's an M3 antagonist, right, for overactive bladder. So I want you guys to make this tie-in. There's a lot of ways that the USMLE can test these receptors, and that's what I wanted to try to highlight with you guys here. Now, I did want to tie in some micro because we know that's highly tested on STEP as well. And I want you guys to use in the chat what bacterial enterotoxin is going to activate your GS pathway. What bacterial enterotoxin is going to activate your GS pathway? Yep. See lots of Vibrios. If you're saying Vibrio, you're absolutely correct. And I want you to remember that this enterotoxin, right, is actually going to permanently activate our GS. We've talked about what GS does, right, with increasing cyclic AMP. That's going to increase our intestinal chloride secretion and cause this classic profuse rice watery type diarrhea. So look out for that. That's another way they can test your GS pathway. Now to contrast this, what's another bacterial toxin that inhibits our GI? Yep. If you are saying pertussis, you're absolutely correct. And reminder that our pertussis toxin, right, classically with our whooping cough, is going to hydrolyze our ADP ribosylation of the alpha subunit of GI, right? And that's going to cause that classic, paroxysmal. Remember, you have the phases of pertussis, your paroxysmal and catarrhal stages, but that's going to inhibit binding with GPCR and cause that classic whooping cough. Very, very good, everyone. Great work in the chat. Now, I did mention that we do have our receptor tyrosine kinases as well that I want to touch on. And I want you to associate growth factor. Whenever you see growth factor, epidermal growth factor, platelet-derived growth factor, vascular endothelial growth factor, insulin, I remember it because it's an anabolic hormone, right? So it causes growth. It builds things. I want you to remember growth factor with receptor tyrosine kinase. I want you to remember that these are going to be activated by a ligand-induced dimerization, autophosphorylation, right, of these tyrosine residues. And very, very important to make the integrations as well with something like IGF-1, right, for acromegaly. That's another key one to keep in mind. Now, to contrast this, our non-receptor tyrosine kinases, right, these are our JAK-STAT mediated ones. And I want you to remember growth hormones, okay? So these ones were growth factor, these are growth hormones. And then I also want you to keep in mind these other high-yield testable ones like the erythropoietin and thrombopoietin, okay? Remember EPO, right, stimulates our bone marrow, and then TPO is responsible with our platelets. And then I did want you to keep in mind prolactin because we saw that a lot of our other pituitary-related hormones came from our GS and GI pathways, but I want you to keep in mind that prolactin is a non-receptor tyrosine kinase. Okay, everyone? And the last integration and last point I wanted to make here is that we talked a little bit about our second messengers, right? Cyclic AMP, cyclic GMP, right? And I want you guys to tell me what what hormones are going to be acting on our cyclic GMP pathway? In the chat box, guys, everyone. I see ANP, BNP. You are absolutely correct. And nitric oxide. Very, very good, everyone. So you're correct. And I remember that they all start with the letter N. Our natriuretic peptides are ANP, BNP, and our nitric oxide. Okay. And now the last thing, right, this pharm integration I wanted to make is that cyclic AMP and cyclic GMP are what are known as second messengers. Okay. And they classically will cause vasodilation. Okay. And what actually breaks these down is an enzyme called our phosphodiesterases, right? And so we give phosphodiesterase inhibitors, right, to prevent the breakdown of cyclic GMP and cyclic AMP to cause vascular smooth muscle vasodilation, right? So for instance, pulmonary hypertension, right? We give a PDE inhibitor called roflumilast, right? Or in erectile dysfunction, we might give sildenafil. Okay, so those are just another integration here to bring everything together. And the last thing, guys, is don't use those pharmacological agents in patients with hypotension, right? Because that can cause severe hypotension and worsen and decompensate the patient. Okay. So hope that was all helpful, and you guys were able to make some nice integrations with the receptor signaling, how that ties into some of the micro as well as pharmacology. All right, moving on. Let's do some hypothalamus and parathyroid integrations. This is another discrete question. We do have more vignette questions coming up, but this is just a quick active recall style question. So which of the following structures are responsible for secreting antidiuretic hormone and oxytocin? Yeah. Okay. A lot of you are saying A, and I might have not wrote this question. I maybe need to be a little bit more specific, but you guys are correct, and I will fix the slide here. There's just a nuance in the language here. We know that secreting, right, is going to be our posterior pituitary, which is our neurohypophysis. But what produces these hormones, right, is our supraoptic nucleus. Yes, exactly. It's stored in the posterior pituitary. But it's actually, I guess, produced and secreted via our supraoptic nucleus. So I'm sure you guys got the concept down if you said both A or D, but I did just want to draw in on these topics, okay? And it'll make more sense here. But keep in mind, right, we have our hypothalamus and our pituitary. And there's specific nuclei that we need to be mindful of and integrate with some certain pathology and physiology, okay? Starting off with our preoptic nucleus, okay? These are going to secrete our GnRH. And this pathology that you got to keep in mind here is going to be Kallmann syndrome. And reminder that this is a lack of migration from the preoptic neurons, from the olfactory bulb to the suprachiasmatic nucleus. And that's why you classically get this anosmia as well. Because not only is it defective olfactory placode from the GnRH neurons, but that's also coming from the olfactory bulb, right? It's a problem with projection from the olfactory bulb to the suprachiasmatic nucleus. And so classically, guys, I want you to think of the two key features of Kallmann, and that is hypogonadotrophic hypogonadism, meaning coming from the hypothalamus itself, you're getting low LH and FSH, and that's going to consequently cause, right, low hormones in the peripheries as well, right, which is why you get your hypogonadism. And then also keep in mind that classic anosmia with Kallmann syndrome. Next, our paraventricular nucleus is responsible for ADH, TRH, CRH, somatostatin, and oxytocin. Our supraoptic nucleus is associated with production of ADH and oxytocin. Okay, and I want you to keep in mind with our supraoptic nucleus, right, that these ones are going to be stored, right, as we mentioned back to the question here, they're going to be stored in the posterior pituitary and released by neurophyses and axonal connections. Okay. And the big tie-in I want you to make with the supraoptic nucleus, with ADH in particular, is your diabetes insipidus. And I want you to be able to differentiate diabetes insipidus, both the nephrogenic, central, and primary polydipsia. Oftentimes, guys, an arrow question that USMLE will test is how to differentiate those. And first and foremost, right, you're going to do a water restriction test. That's going to help you rule out the primary polydipsia. And then you're finally going to do a desmopressin stimulation test, right, to see whether the kidneys are receptive or not. If they're not, it's nephrogenic, right, because the problem is in the damages in the kidney itself, okay? So that's just a quick tie into how they might test the supraoptic nucleus. And Now we're going to move into the posterior and anterior pituitary. The posterior pituitary, right, we said is going to be known as the neurohypophysis. And this is actually going to be derived from the neural ectoderm. Okay, very important to understand that. I want you to think of the two hormones that it produces, and that is antioxidant, anti for antidiuretic hormone. And we know that has implications with our regulating our plasma osmolarity, blood pressure, and urine concentration. And classically, this is going to be, in terms of the receptor types, right? It's going to bind our V2 receptors in the collecting duct. Reminder, V2 is our GS pathway versus our V1 receptors, where our GQ. Okay, just some active recall going back to receptor signaling. And these are going to increase those aquaporin channels, right? Which is going to increase H2O reabsorption. Now, we can sometimes get too much ADH hormone, and that's something called SIADH, syndrome of inappropriate antidiuretic hormone, right? And you're going to look out for things like intracranial infection, trauma, tumor, a paraneoplastic syndrome from your small cell lung cancer, and certain drugs as well, like carbamazepine, can cause your SIADH. Okay, so do look out for those. And the other tie-in I did want to make is that although ADH is going to cause excessive free water retention, it actually is going to cause something that we know as euvolemic hyponatremia. Because actually, guys, the body's really smart. What's going to happen is aldosterone levels are actually going to decrease in response to this excessive ADH. And when we decrease aldosterone in ANP and BNP, right, those natriuretic peptides, we're going to increase our sodium secretion in the urine, and hence bring free water back. So that's why we get this euvolemic hyponatremia, because we have a compensatory mechanism there. Yeah, really good tie in there, Dr. Yuma, in the chat. And then the other hormone is our oxytocin, and you know that that's responsible for uterine contraction and breast milk production. Reminder, we give things like tocolytics like nifedipine to inhibit uterine contraction, okay? Now, our anterior pituitary is going to be derived from our adenohypophysis, right? And I want you to remember that our adenohypophysis, right, the anterior pituitary comes from our oral ectoderm, our Rathke's pouch. And classically, right, keep in mind the craniopharyngioma, right, which is that suprasellar calcified mass that's going to cause like classic hypopituitarism, that diabetes insipidus in a child. So keep an eye out for that. And I really want you to remember, guys, anterior pituitary, adenohypophysis, blood vessels right through your hypophyseal arteries. It's going to be your oral ectoderm, Rathke's pouch. Posterior pituitary, neuroectoderm, neurohypophysis is going to be the axonal connections, okay? Now, the easy way to remember your anterior pituitary hormones is FLATPEG, FLATPEG, okay? And then we know that these FSH, LH, ACTH, TSH, prolactin, and growth hormone are going to have effects, right? These are what we call tropic hormones, which have effects on our effector glands, which are down here. And you guys can go through this in your own time, but be sure you understand all the relationships of these and the negative feedback systems as well, okay? Now we're moving on to the adrenals. More of a vignette style question here. We have a 50-year-old who presents to his primary care physician after noticing increased acne in the development of back hair. He has noticed that the bruise is easier and that his face is flushed. He's a longtime smoker. The patient undergoes a variety of lab tests. One of these tests demonstrates no decrease in cortisol following the administration of high-dose dexamethasone. Which of the following is a possible etiology of this patient's high cortisol? Everyone in the chat box, I want to see you stay active and engaged. I'm seeing lots of C's, some B's. Okay, really good. If you're saying C, you are absolutely correct. If you're saying B, don't worry. We're going to go through how to differentiate an ectopic cause of ACTH and a pituitary adenoma, okay? But all of these, okay, are what we know as Cushing's syndrome, okay? And Cushing's syndrome is going to be due to too much cortisol production. And I first just want to touch on cortisol. So reminder, right, our adrenal has 3 layers. GFR, glomerulosa, fasciculata reticularis, right? Salt, sugar, sex, aldosterone, cortisol, and our androgens, okay? And our fasciculata layer, right, which says sugar, is our cortisol. And I want you to remember a big fib to remember the actions of too much cortisol. It's going to increase appetite. It's going to increase blood pressure, increase insulin resistance, increase gluconeogenesis, decrease fibroblast production, decrease your immune response, and decrease bone formation. Okay. And all of that together, right, it classically creates this Cushing's syndrome. And you can think of it as a cushion, right? And I made this little fun kind of caricature here to help you remember the moon face, the truncal obesity, decreased muscle, and the classic hirsutism. But I want you to turn your heads to this side of the chart here now, which is going to help us delineate between primary, secondary causes of Cushing syndrome. Okay. So primary means the problem is at the adrenal level itself. Okay. And this is classic for something like a cortical adenoma. Okay. So essentially, you're getting too much production of cortisol right from the adrenal itself. And that's going to negatively feed back to the pituitary and decrease ACTH production. Okay. So that works via an independent mechanism. Now, here are the two answer choices that you guys were putting in the chat box, which is our pituitary adenoma, that classically is our Cushing disease, which is right where you have too much ACTH coming from that pituitary adenoma, and that's going to increase cortisol. Okay, that's ACTH dependent. And then we have our ectopic causes, right, such as a small cell lung cancer, which is just going to produce too much ACTH, right? It's not related to that whole axis. It's just producing too much ACTH, which is hence going to act on our adrenals, right, that fasciculata layer, and increase our cortisol. Now, the way to delineate these is through my dexamethasone poem. If you haven't seen this poem before, I hope it does help you after you do read it now. But essentially, right, I want you to keep in mind the three components of our HPA axis, right? Our hypothalamus, adrenal, and the three layers. Now, classically, right, dexamethasone is going to suppress this whole axis, right? That makes sense. It's an exogenous steroid, right? It's going to turn down the whole axis all the way starting up at the hypothalamus, right? If we don't, this is where you guys can help to differentiate this, right? If we don't get suppression at a low dose, so we start off with a low dose dexamethasone suppression test, right? So if it is suppressed, good. We don't have any pathology. It's a normal response to the body. If we do get suppression, no suppression at a low dose, that's going to be a lower level problem. Okay, so think of it like this: the adrenal, right, in a cortical adenoma, right, it's just producing so much cortisol that nothing's going to shut that down. A low dose is not going to shut that down. It's producing so much automatically that that's just going to continue to produce. However, if we do then increase our dexamethasone to a high dose, and that does shut down this axis, that's going to be our higher level problem, our pituitary. But in the question, guys, we didn't see suppression at a high dose. If we don't see a suppression at a high dose, which is our last step in this test, in this dexamethasone test, then we have an ectopic cause, an extra problem, right? Which is due to something like a small cell lung cancer. And I want you to keep in mind the other paraneoplastic syndromes, okay, on the USMLE. For small cell lung cancer, guys, the three to keep in mind is your ectopic ACTH production, your Lambert-Eaton syndrome, and your SIADH, okay? I want you to contrast that with your PTHRP, right, your parathyroid-related protein, which can cause hypercalcemia, which is associated with your squamous cell carcinoma. So most of your paraneoplastic syndromes are associated with your small cell lung cancer, right, Lambert-Eaton, ACTH, and SIADH. But keep in mind that other one, right, when you get hypercalcemia, PTHRP, your squamous cell carcinoma, okay? Now, this next question is another arrow style question that I want you guys to try out, and let's read through it, okay? So a 30-year-old woman evaluated for a 3-month history of progressive fatigue, decreased appetite, and 4.5 kilo weight loss. The patient has type 1 diabetes and has noticed decreased insulin requirements over this time. She has no other medical conditions and does not use tobacco, alcohol, or illicit drugs. Physical exam shows a generalized increase in pigmentation of the skin, especially involving the palmar creases. Measurement of serum cortisol before and after administration of exogenous ACTH shows no difference in the levels. Which of the following changes in lab values is most likely present in this patient? So guys, take a second to go through the different up and down arrows here. But when you're ready, put your answer in the chat box. Using a lot of the principles, guys, we just talked about with that HPA axis, you should be able to answer this question. Really good. Awesome, everyone. I want everyone to put their answer in the chat. If you're saying B, you are absolutely correct. And the first thing I want you guys to do is to pick the low-hanging fruit when you see these arrow style questions, okay? In this, can you guys put in the chat box what your kind of primary diagnosis here, your working diagnosis is of this vignette? Yep. Yep. If you said Addison's, Juliet, really good job. Really good job, guys. Yep, Deandra, Mary. If you said Addison's, you're absolutely correct, right? Awesome. And we know that in Addison's disease, right, we get this adrenal insufficiency, this primary adrenal insufficiency, right? And we just talked about the three really important layers of our adrenal, right? Glomerulosa, fasciculata, reticularis. And if we have problems with our aldosterone, right, aldosterone is going to have effects on numerous electrolytes. And classically, right, it's going to what? It's going to bring in sodium. It's going to resorb sodium and bicarb, and it's going to secrete, it's going to dump hydrogen and potassium, right? So first and foremost, guys, pick your low-hanging fruit. We know that sodium can't be normal. We just talked about aldosterone and its role in reabsorbing sodium. So A and D are crossed out, okay? Now let's differentiate between B and C, okay? I can see that our potassium is a key differentiator between these two. What did we just say aldosterone does? It secretes potassium. So if we have primary adrenal insufficiency, if we have a problem secreting potassium, what do you expect your potassium levels to do? Increase, right? We're going to get hyperkalemia, right? And similar to bicarb, right? If we can't resorb bicarb, what's going to happen? You have decreased levels, we're dumping it out, right? And then finally, you don't really need to know this to answer the question, but the reason chloride is increased in this case is due to a concept called electroneutrality. Essentially, all the cells in our body try to maintain this homeostasis of cations and anions. And we know that bicarbonate, right, HC3O minus, is a negative anion. We also know that chloride is a negative anion. What the body does to compensate, because we're losing so much bicarb, this negative ion, it does everything it can to resorb another negative ion. And so that's why our chloride is going to increase, okay? That's just a fun little tidbit, probably not going to be tested, but make sure those other principles with aldosterone and electrolyte is down. And similar to what I just talked about, we have our three different types of adrenal insufficiency. Our vignette here was our primary, right, adrenal insufficiency, which is classically known as our Addison's disease, which in the developed world is most likely due to an autoimmune cause. In the developing world is due to tuberculosis. And I did want to tie in this really key aspect, guys, of melanocyte stimulating hormone and this pigmentation you get, okay? So reminder that if we don't have, if in primary adrenal insufficiency, right, we're not getting proper cortisol function, right? We have low cortisol. Well, what's going to happen is normally we have this feedback system of ACTH, right? And because we have low cortisol, that's going to tell the pituitary, we need more ACTH. We want to generate cortisol. Why aren't we producing cortisol? We need to stimulate more ACTH, guys, to produce more cortisol. So we're going to have this positive feedback system. And ACTH, guys, alongside MSH, which is your melanocyte stimulating hormone, right? That's going to activate POMC, which is going to cause this increased pigmentation, classically that you see in Addison's disease. Now, we can also get secondary and tertiary cause of adrenal insufficiency. Classically, remember tertiary for treatment, right? It's usually caused by abrupt cessation of corticosteroids. And then remember secondary for SALT, because your SALT is still intact. And you're going to think of things like a pituitary tumor or hemorrhage for that, okay? Fun little mnemonic, guys, to remember your Addison's features is Addison's patients get fatigued. You have fatigue, antibodies, which is an autoimmune process, of course. We get our triad of hyponatremia, hyperkalemia, and azotemia, right, as it relates to our aldosterone. Increased pigmentation we talked about. You have GI weight loss, nausea, vomiting, eosinophilia, and decreased blood pressure, hypotension, okay? Now, we are about halfway through, everyone. Really, really great job in the chat box, and hope you guys are enjoying this session. I did want to just quickly mention that the giveaway of my endocrinology guide that I have here is going to happen in my Discord after this webinar. And this is also an exclusive 50% lifetime discount code for $4.95 per month to join our community of thousands of like-minded individuals. We host webinars, lots of interactive ways to kind of collaborate with each other, study groups, etc. And stay tuned. We did mention at the start of this webinar that we're going to be kind of releasing a private advising and mentorship program. We're really going to be able to help you one-on-one through your applications, test prep, etc. So stay tuned. Take a picture of this if you need, but we will move on to the rest of this presentation. All right, embryology, everyone's favorite. Let's get into it. We have a 7.5-pound female newborn born at full term to a 25-year-old G1, P1 woman. ABCAR scores are 8 and 9 at 1 minute and 5 minutes, respectively. Pulse is 115, temp is 98.6, and blood pressure is 55/35. Okay. Serum panel reveals hyponatremia and hyperkalemia. The next day, examinations finds clitomegaly. Ultrasound reveals normal development of ovaries and uterus. Which of the following enzymatic deficiencies does this child most likely have? Very fun are congenital adrenal hyperplasias, guys. It is, the USMLE loves testing these. Absolutely loves testing these. Really great, guys. Put your answer in the chat box. If you're saying A, you are absolutely correct. 21 hydroxylase deficiency, right? Your classic salt wasting form. I wanted to also just tell you guys though that the USMLE could test this in another way. Reminder that this is a whole pathway, right? They could say what 17 hydroxyprogesterone, for instance, would also be the correct answer here if they said what serum, what level of marker would be elevated in this case, and that would be 17 hydroxyprogesterone, which is increased in 21 hydroxylase deficiency because that's upstream from the enzyme 21 hydroxylase. Okay, so they can test it in a few different ways. Keep that in mind. But really good job if you said A. And let's get into my fun MedSchoolBro trick. That's going to save you so much time that I used on my step 1 exam because I had a question on this. But guys, all of them are going to be autosomal recessive. And there's going to be 3 simple rules that you're going to follow to answer any one of these questions. All right. Step 1, draw this. You're going to draw MA, 11, 17, and 21. And these each represent 11 hydroxylase deficiency, 17, and 21. Okay. Then on all your ones, because your one look like a little arrow, you're going to draw it up, okay? Your M and your A are going to correspond to mineralocorticoids and androgens, okay? We've already discussed at length what our mineralocorticoids like aldosterone do, right? They reabsorb sodium, they reabsorb bicarb, and they secrete potassium and hydrogen, right? If we reabsorb sodium, right, we bring free water back, and that can cause what? That can cause hypertension, right? In this patient here, we had a 55/35, right? So we didn't get that. Maybe we're thinking down here, which makes sense. Our mineralocorticoids weren't elevated. However, we did see the clitomegaly, right? And so A is going to be your androgens. And what do androgens cause in the setting of congenital adrenal hyperplasia, right? Precocious puberty, right? Virilization, right? So I hope this trick, does everyone understand this trick? M-A, draw an up arrow on all the ones, and it's going to tell you if mineralocorticoids or androgens are increased, and then in the vignette, you can kind of depict it. I hope that helps. But just to kind of reinforce this, guys, the 11 has both up arrows on M and A, so mineralocorticoids and androgens are going to be high, so you're going to get hypokalemia, hypertension, and metabolic alkalosis, right, from our aldosterone, and our androgens are going to cause our precocious puberty. Next, 17. Well, 17 only has an up arrow on our mineralocorticoids, so you're going to still get the hypokalemia, hypertension, and metabolic alkalosis, right, from the aldosterone, but now we don't have androgens. So classically, guys, if the vignette presents a patient with delayed puberty or sex infantilism, then you're going to think of this 17 hydroxylase deficiency where you don't get these secondary sex characteristics, okay? And finally, in the case that we just saw, which is 21 hydroxylase deficiency, which is the most common type, it has only an arrow on the androgen side. So you're not going to have the effects of your mineralocorticoids like aldosterone, and you're going to have hyperkalemia, hypotension, which we saw, and metabolic acidosis. The androgens are going to cause precocious puberty, as we saw in the vignette. Okay, so hope this helped. Again, a fun way to also remember that 17 hydroxyprogesterone is elevated in 21 is, look, 17 is right above 21. So you can also remember that 17 hydroxyprogesterone is elevated in your 21 hydroxylase deficiency. Okay. Hope that was helpful, guys. Moving on to thyroid. We have a 32-year-old male with a recent history of thyroid storm. He's now complaining of persistent mouth ulcers and fevers. He was started on anti-thyroid medication as part of the treatment plan. Which of the following adverse effects is most likely associated with the drugs administered? Now, a lot of these might be implicated, but which one in particular is going to be responsible for your persistent mouth ulcers and fevers? This is more of just a active recall discrete question. Really good, everyone, if you're saying B. Agranulocytosis, you're absolutely correct. And let's dive into the thyroid. So thyroid storm is a complication if hyperthyroidism is not completely treated. And I want you to remember the 4 Ps of treatment: propranolol, propylthiouracil, prednisone, and potassium iodide. Now, in particular, we're going to really focus here on the propylthiouracil. But first, I wanted to just go through some physiology. The USMLE loves testing thyroid hormone production and synthesis, okay? Let's follow along this diagram, and then we're going to go into the integrations, okay? So keep in mind this kind of 3-4 level interface. We have our peripheral tissues, our blood, our thyroid follicular epithelial cells, and then our follicular lumen, okay? And first and foremost, TSH from our pituitary, right, is going to increase our thyroglobulin production. And reminder that we're going to have iodine being uptake from the blood. You know, classically, we're going to get it from things in our diet, right? And so iodine is going to be uptaken. We're going to have TSH stimulating thyroglobulin production. All of this is going to be transported into our follicular lumen, where a lot of the magic happens, where thyroid peroxidase, TPO, is going to work its magic, okay? And thyroid peroxidase has 3 main functions. And I want you to remember TPO has 3 powerful orders. It's going to be involved in oxidation, it's going to be involved in organification, and it's going to be involved in coupling, okay? Reminder that, right, iodine to iodide is going to happen with our oxidation. Organification is going to occur, right? And then finally, our coupling is going to occur where we get our MIT and DITs. MIT is mono, DIT is di. So 1 di and 1 mono is going to become T3, 2 dis are going to become T4. Anyways, all the magic happens in the follicular lumen. TPO is a really key mediator, obviously. And then we're going to get proteases that cleave off our T3 and T4 from our thyroglobulin, and then they're going to go back into the circulation. Now, really important to understand that T4 is going to be produced more, okay? T4 more. We have more of T4, but T3 is more potent. And so 5' deiodinase, right, in our peripheral tissues is going to convert our T4 to T3, and T3 then has effects on those effector glands, okay? And I want you to understand, guys, that classically, right, PTU, propylthiouracil, right, and methimazole are going to inhibit a thyroid peroxidase, so all of these steps here. However, propylthiouracil, the Ps, I want you to remember, also inhibits peripheral conversion. So propylthiouracil is also going to inhibit 5' deiodinase. Okay, that's you're going to remember that. Now, another high yield concept, guys, make sure you're paying attention right now, is going to be your thyroxine binding globulin. Okay, I want you to know that in pregnancy or patients taking oral contraceptives, right, this is an increased estrogenic state. Estrogen is going to increase production of our thyroxine binding globulin. If we have increased production of this binding globulin, right, it's going to bind more of our hormone, and that's going to increase the levels, right? We're going to get increased total T3 and 4. However, think about it. If it's now bound up, we're going to have less free T3 and 4 in our circulation, okay? Really, really important, guys. They test this so much, okay? Finally, I wanted to end with our pharmacology integration and the key way to differentiate propylthiouracil and methimazole, okay? I said both work as a TPO inhibitor. The way to differentiate them is that P is going to also inhibit peripheral conversion, right, at our 5' deiodinase, propylthiouracil. A MedSchoolBro mnemonic, guys, remember the P is a PTU and the M is a methimazole, okay? PTU blocks peripheral conversion and is used in pregnancy in the primary trimester. So just really, really important to know that PTU you can use in the primary trimester. Methimazole is used in the mature fetus, 2nd and 3rd trimesters, guys. They both are going to classically cause this neutropenia and agranulocytosis, which we saw in our vignette. PTU is going to also cause hepatotoxicity. And then we talked about why, yes, exactly. Methimazole is teratogenic in the 1st trimester. Really, really good, everyone. Hope this all tied in everything together for you. Very, very important, very high yield. Next, parathyroid. Everyone stay active, stay engaged. We're getting towards the end. 52-year-old woman presents to the clinic for an annual well exam. Routine lab tests demonstrate elevated levels of hypercalcemia. The patient reports some diffuse abdominal pain over the past 2 weeks, but otherwise denies any chest pain, palpitations, or fatigue. A follow-up PTH level is found to be elevated. Further investigations will most likely reveal. Everyone in the chat, if you're saying B, you're absolutely correct. Parathyroid hormone is going to increase serum calcium. It's going to phosphate trash, low serum phosphate, and then we talked about high serum PTH. Okay. Now, let's first talk about our parathyroid hormone. So where does it come from? It comes from our parathyroid. Easy. It comes from the chief cells, right? And these chief cells are going to be responsible for increasing serum calcium because we increase reabsorption in our distal convoluted tubule, and it's going to phosphate trash, right, in the DCT. Okay. So mnemonics is that PTH is going to be phosphate trashing hormone, and remember that it does this at the proximal tubule. Very, very easy to remember that. Okay, guys. Now, that answers our question, but let's tie in some pathology here. On our x-axis, we have calcium levels, and our y-axis, we have PTH. I want you guys to put in the chat box here. We're gonna have a good, nice active recall session now, and we're gonna go through 4 pathologies. Okay, we have primary, secondary, hyper, and hypoparathyroidism, and I want you to tell me which one goes where. In this bottom quadrant here, what would we have? Okay, out of the 4 I just mentioned, when we have low calcium and low parathyroid hormone, guys, what do we have? So guys, secondary is going to be up here. We're going to get to that in a second, but think about it, guys. We have low PTH. Think about that first. Low PTH, we have hypoparathyroidism, right? I want you to think of, sometimes your parathyroids can be damaged in surgery. You can have autoimmune causes. And the classic, guys, always, we're going to integrate this DiGeorge syndrome. They love testing it, right? Defective 3rd and 4th pharyngeal pouch leads to this parathyroid aplasia. Keep that in mind. Next here, right, we have low PTH, but high calcium, right? We talked about this earlier. Our PTH-independent hypercalcemia, right? Our paraneoplastic syndrome of squamous cell carcinoma, which increases the PTH-RP. PTH-RP-related protein. It's not our PTH, okay? Next, this is, guys, where we have our secondary hyperparathyroidism. So in classic patients with chronic kidney disease, right, we're going to have poor calcium reabsorption. If we have poor calcium absorption, that's going to signal back to the parathyroids and tell the parathyroids, hey, we need to pick this PTH up. We need more calcium. We gotta increase PTH. So that's going to be a classic negative feedback system that you see there. Look out for patients with CKD. And finally, this top right quadrant, guys, is your classic primary hyperparathyroidism, right? You have a parathyroid hyperplasia. That's going to increase PTH. Downstream, that's going to increase calcium, as we talked about, okay? Now, whenever you see states of hypercalcemia, I want you to remember bones, stones, Crohn's, moans. Bones for painful bone conditions, stones for kidney stones, Crohn's for GI symptoms, and moans for just the non-specific signs of lethargy, fatigue, etc. Okay, so keep in mind they can present a patient, right, in a vignette like this and tie this back to the lab values. They can ask everything in between. Okay, so hope this helped, guys, and really, really important also to remember DiGeorge syndrome in here and the 3rd and 4th pharyngeal pouch. And then the other thing, guys, is really important to know PTH and its role in osteoblast and osteoclast mediation, okay? So reminder that PTH, right, is going to bind PTH receptor on osteoblasts. That's going to induce osteoblasts to make rank L. Rank L binds rank, right, on osteoclast, and that's going to increase PO4 and calcium concentration, okay? We talked about how the net effect, though, is going to be increased calcium because we get increased reabsorption in the DCT, and then we get proximal tubule hyporeabsorption of phosphate, which is why we get decreased levels. And guys, the last tie-in I want you to remember is how PTH affects this in both an intermittent and chronic time period, okay? So if you get low intermittent PTH, just boluses of PTH, right, you're going to build bone. So I want you to remember low intermittent boluses build bone versus chronic kills bone. Okay, so if you chronically administer PTH, and there's certain drugs, of course, that does this, you're going to kill the bone. If you have a low intermittent PTH, like our teriparatide, right, that drug, that's going to cause building bone. And then lastly, estrogen, remember its implications with osteoprogenerin, right, OPG. That's going to increase OPG. That's going to inhibit this rank L to rank interaction, which is inhibit our osteoclast, and that's going to be protective for osteoporosis, right? Which is where in states of estrogen deficiency, right, we get increased bone and osteoclastic reabsorption, and that's why we have and patients are at risk of osteoporosis. Okay, you want to make those tie-ins there. Remember how PTH and estrogen plays a role in your osteoclasts, osteoblasts. We're getting close to the end, everyone. Stay active and engaged for these last ones. 48-year-old man presents to the emergency department with recurrent episodes of diaphoresis, palpitations, and confusion. Patient reports feeling shaky during these episodes, which occur unpredictably throughout the day. On examination, his vitals are within normal limits during the visit, and a random glucose measurement is found to be 45 milligrams per deciliter. Administering glucose resolves the symptoms. What marker is most likely to be elevated following this intervention? Nice. You're saying C. Yeah, if you're saying C, you're absolutely correct. We're going to go into this in a second here on this next slide. What we just saw is a patient with a classic insulinoma, okay? And I want you to remember this rule of tens, okay? 10% become malignant, 10% are part of our MEN1 syndrome. And guys, we are going to go into men's syndromes on the next slide, but really important to make those integrations. And as well, reminder that in our parathyroid, we talked about parathyroid hyperplasia, right? And that's related to our men as well. Insulinoma, right? Classically from our beta cells. Glucagonoma from our alpha cells. That's going to cause dermatitis, diabetes, decreased weight, depression, diarrhea, DVT, and then somatostatinoma from our delta cells. Remember the S's, sugar, stones, and steatorrhea. Okay. Now, they do test insulin synthesis, so it's important to understand what happens in the ER, Golgi, and granule. But essentially, we're going to have pre-proinsulin, which is going to be cleaved to proinsulin, and then finally, proinsulin is going to be cleaved by pepsidases, right, into C-peptide and insulin. And the key thing you need to understand with this all is what C-peptide is. Okay, C-peptide is going to be a marker of endogenous insulin secretion. Okay, so I want you to be able to contrast this, and it's really, really important, so focus. So if we have someone taking, right, superstitious insulin, right, for instance, think of malingering, think about, that type of picture, right? We're not going to see increase in C-peptide because that is coming from an exogenous use, superstitious use, right? And so classically, if patients come in and we suspect this hypoglycemic state and we're trying to differentiate between an organic cause or a cause due to a different medication like a sulfonylurea or meglitide, which do increase endogenous, right? A good way to know this is look at our C-peptide. If C-peptide is not elevated, then it's most likely going to be superstitious use, right? Exogenous use. Two drugs to keep in mind, guys, I just mentioned is your oral sulfonylureas and your meglitides. These are going to increase endogenous insulin, and we just talked about how endogenous insulin is going to increase C-peptide, right? Because it comes back to this insulin synthesis pathway, okay? The other thing I want you to keep in mind, guys, is that insulin, right? Tying back to our receptor signaling is our tyrosine receptor kinase, right? Remember insulin growth. We said our growth factors, it's anabolic. And it's going to increase processes, right, that build. So anabolic, so glycogenesis, lipogenesis. And it's going to inhibit things that break down, right? Lipolysis and keto acid formation. Okay. I hope that was helpful. C-peptide is high yield. Now, I said we're going to get back to our MEN syndromes, which are very high yield. And you're going to remember MEN1 with our 3 Ps, pituitary adenoma, parathyroid hyperplasia, right? Recall back to those slides, and our pancreatic tumors, such as our insulinoma, right, that we just saw. Next, our MEN2A syndromes is going to be 2 Ps and 1 M. So we still have our parathyroid hyperplasia, but this time we have our medullary thyroid carcinoma and our pheochromocytoma. Remember our pheos, right, with our Ps, right, palpitations, perspiration, pallor. You're going to have the increased HVA and VMAs, right? Important to understand that. And then MEN2B syndrome is going to be 2 Ms and 1 P. Okay, and so this is classically, right, our marfanoid body habitus, medullary thyroid carcinoma, and pheochromocytoma. Reminder that these are associated with our RET oncogene. Now, I did want to make this integration with Marfan syndrome, as we can see here, and just talk about how marfanoid appearance can come up on the USMLE. So reminder, guys, chromosome 15, right, our fibrillin 1 mutation causes bad and poor elastin. And we know elastin is in various aspects of our body, right? It's in our heart, which we can cause mitral valve prolapse, arachnodactyly, right, in terms of our joints. Retinal detachment. I want you to remember, guys, a fan, where do you look? A fan is on the ceiling. You look up. Fan is going to help you remember an upward lens dislocation because we're going to contrast that with homocystinuria, which is a down and in, okay? Retinal detachment, we talked about flat feet, flexible joints, aortic aneurysms, pneumothorax, and scoliosis. Look out for that pectus activatum and other features as well, okay? Now, I want to contrast this, guys, with homocystinuria, which also is going to appear in a vignette with these marfanoid features. The key distinguish, guys, between the two is going to be I talked about homocystinuria being a downward dislocation because marfan, fan, you look up, upward dislocation. Homocysteine is also going to, so in homocystinuria, right, you get decreased methionine synthase or cystathionine synthase, which is going to have a buildup of this homocysteine. And homocysteine is actually pro-coagulant, right? It's going to cause thrombosis and atherosclerosis. And so look up for those features as well, along with that intellectual disability. And I want you guys just to remember how your B6 and B12 are cofactors in this pathway, okay? Our last slide, everyone. Stay ready. We're almost there. Final one is going to be diabetes pharmacology. We're going to be doing a nice active recall style here, okay? We have a 60-year-old male with poorly controlled type 2 diabetes who presents to the clinic for medication review. Despite multiple oral anti-diabetic agents, his hemoglobin A1C remains elevated. After discussing the potential risks and benefits, the physician decides to initiate new medication. Several weeks later, the patient returns for a follow-up visit. Lab results show an improvement in glycemic control, but glucose is found in the urine. What is the most likely medication responsible for these symptoms, everyone? Put your answer in the chat box. Really, really good if you picked up on the glucosuria and our gliflozins, because guys, glucose flows in the urine with our gliflozins. Really, really good job. Let's do a quick active recall here. What I want you guys to do is I want you to tell me some of the key aspects of the mechanism of action and the side effects of metformin, okay? Metformin in the chat box, guys. So put what you know about metformin. Lactic acidosis, AMPK activation, love it. Yep. B12, yep. Diarrhea, really, really good. It also can classically cause weight loss as well. So absolutely correct if you said that AMPK activation, right? It inhibits this glycerol 3-phosphate dehydrogenase. Essentially, it's just going to increase insulin sensitivity, increase pathways to increase insulin sensitivity. Look out and be cautious in patients with renal insufficiency. I saw a lot of you guys put the lactic acidosis, which we want to be aware of, as well as GI upset, B12 deficiency, and weight loss. Classically, guys, you're going to be euglycemic, though, using this agent. Next, pioglitazone. I want the mechanism of action and key side effect of pioglitazone. Your glitazones. Let's see it in the chat box, everyone. Let's finish off strong here. Activates PRAR gamma. Very, very good. Weight gain, edema, risk of fractures. Very good. All of you guys are on it. Absolutely correct. I want you to remember glitazone party to help you remember that PRAR gamma activation. And really, really good, guys. Yep. Exacerbate heart failure, weight gain, edema. Very, very good. Next, sulfonylurea. I want you to tell me the mechanism of action and a key side effect that you cannot miss, guys, with your sulfonylureas. Hypoglycemia. Yep, you guys are on it. Potassium channels and hypoglycemia are the key things you guys want to look out for here. And also look out for this disulfiram-like reaction, guys. Reminder, disulfiram and ethanol, right? The interaction will cause this classic flushing, tachycardia, and hypotension, and you can get that in a first-generation sulfonylurea like disulfiram. Your second gens are your glys. So that's another way to remember hypoglycemia, okay? So gly suffixes, GLY or GLI, keep in mind for your second generation sulfonylureas, but really, really good if you guys said potassium channels and closing those ATP sensitive channels, as well as the hypoglycemia, which we don't want to miss, okay? Meglinotides, how do these ones work? And what is a side effect? Insulin, yep, very good, Tahani. Yep, these are our insulin secretagogues, which are going to essentially stimulate the release of insulin. Again, hypoglycemia is the thing to worry about here. Tying back to our C-peptide, everyone, would we expect to see high or low levels of C-peptide when we administer sulfonylureas and meglinotides? Everyone in the chat box. What's our C-peptide going to do? You guys are exactly on it. Very, very good. GLP-1 analogs are tides. We're almost at the end. 3 more to go, and you guys are off. Tell me about our GLP-1 analogs. Mechanism of action, increase insulin. Yep, but how do they do that? GLP agonists. Yep. Delayed emptying? Yes. Very, very good, everyone. This is going to increase glucose-induced insulin secretion. Classically, guys, I want you to remember that these also exactly decrease gastric emptying and delay that. Look out for some of those GI symptoms, okay, for your side effects. Now, DPP-4 inhibitors, guys, they're related to your GLP analogs. How do they work? What do they do? Are gliptins. Increase insulin secretion, but how? Yes, Jesus. Yep. They prevent GLP-1 degradation. Exactly. So they're essentially going to inhibit the breakdown of these GLP-1s, okay? And then they're going to work by the same mechanism of action to increase insulin secretion. You can remember DPP-4, they decrease peptidase for increasing insulin. Really good. And finally, guys, the answer to our question, SGL2 inhibitors flows in, glucose flows in the urine, right? Glucosuria, and that's going to put patients at risk for UTIs, vulvovaginal candidiasis, and also look out, guys, and stay in caution for renal insufficiency, as well as dehydration with your orthostatic hypotension. And these ones, guys, work in the kidney nephron to decrease absorption in the PCT. Well, guys, that is it. I'm so thankful to have all of you with this session to learn all together here. We had close to 200 people in this session, which was fantastic. Hope you guys found this helpful. If you're studying for step 1 or you're in your dedicated, good luck. I have lots of resources and rapid review guides that I think would help you guys. I have my cardiology, neurology, GI, endocrinology, and MSK derm guide. My infection, pathology, immunity guide. Essentially, guys, I took Pathoma chapters 1 to 3 and the sections of pathology and immunology from first aid and condensed it into my MedSchoolBro ways. And that is going to be here, guys. And I'll just tell you this. It is super, super important that Pathoma 1 to 3 is reviewed before your step 1. If you guys are writing step 1 before I release the guide, be sure to review that. But if you guys see my pathology, immunology guide before you write step, I highly recommend you get it, because I would say when I wrote step, at least, I want to say at least 5 to 10% of questions coming just from those first chapters, okay? And all my mnemonics, my visuals, and fun tricks are all built into that guide. This is the code if you guys want to join our Discord for all webinars, community building, study groups, answering your questions, as well as if you guys want to be updated with our private advising and mentorship program that's going to be launched very shortly, so stay tuned for that as well. We're going to be hosting a giveaway for this endocrinology rapid review guide. All the diagrams and explanations that you guys just saw in this presentation were from my endocrinology rapid review guide. So if you guys want a chance at winning that, head over. If you guys want to purchase it, head over to MedSchoolBro.com. You will find that there. This recording will be posted on YouTube for you as well. Can you repeat the mnemonic for the layers of the adrenal gland? Yes, GFR, glomerulosa, fasciculata, reticularis, salt, sugar, sex, aldosterone, cortisol, androgens. That is it, everyone. I hope this was helpful. Again, stay tuned for my infection, pathology, immunology guide. If you guys are writing step in the next couple of months, highly recommend you get your hands on that. Again, if you want multiple of my guides, where can we find? Yeah, so there's no Harini. I am condensing those chapters. So that doesn't exist yet. I've taken upon myself to incorporate the elements of Pathoma 1 to 3, and I've also taken the high yield concepts from both the pathology neoplasia section of first aid as well as the immunology section of first aid, and I've essentially mashed it all together into one guide. Hopefully, it's going to be ready for you. The digital versions in the next month or so, and then hard copies in a few months. So. Love you guys all. Thanks for tuning in. I'll be doing another session for MSK Derm in likely 2 to 3 weeks, a rapid review session like you saw here, a webinar. So be sure to stay on the lookout for that. But yeah, good luck with your studies. Good luck with your step prep. You guys will all become wonderful physicians in the future. You guys were so on it in the chat. I loved it. Love you all. Thanks for your support. And we will see you at my next webinar covering MSK, derm, and connective tissue. So thanks again, guys, and see you at the next one.